So my disclosure, I do have NIH funding. The objectives, we're going to describe some symptoms of post-stroke depression, understand factors that are associated with post-stroke depression, and then describe best practices to address post-stroke depression. It's kind of amazing to me that even though I've been here now a few times, this is the first time that I'm actually talking about post-stroke depression, which really is my area. So to get us started, I do want to read this clinical vignette. I'm going to have to make this a little bit bigger here so I can see it. So this is Daniel. Daniel is age 52. He had a left MCA stroke 6 months ago. Although he's made significant improvements in his recovery, Daniel continues to experience some expressive aphasia and some paralysis on his right side, which alters his gait and limits the use of his right hand. He's being seen by his provider today for his 6-month outpatient follow-up. Prior to his stroke, Daniel was employed as a mechanic and was the primary provider for his family. He also loved restoring vintage cars, spending most of his free time in the garage of his home, and was an active member of the local classic car club. However, he's not currently employed, and his wife has had to get a second job to support them. His wife says he just sits on the couch and watches TV for hours on end. When she says this, Daniel shrugs and fixes his gaze on the floor. When asked whether he engages in any physical activity, he says that he knows he should, but he lacks energy and gets fatigued easily just doing normal stuff around the house. Daniel has not stepped in his garage because seeing the car he has been working on frustrates him. He feels he's unable to work on it the way he used to and is not motivated to try. He also has not returned any phone calls from his car club friends because he is very self-conscious about his ability to speak. Daniel discloses that he frequently struggles with feelings of worthlessness because he is letting his family down, and that some days he wishes he would have died from the stroke so he wasn't such a burden on his wife. The provider asks Daniel whether he thinks he is depressed. Daniel shrugs and explains that he probably doesn't feel much different than most people who have had a stroke. I would like for you to keep this case in mind as we talk a little bit more about what post-stroke depression is and looks like, and how you would identify and treat it. We're going to come back to Daniel a little bit later in the talk. So just kind of for reference sake, Daniel is a fictional case. However, he is heavily based on a real client that I saw for a while. So what's the issue? I think it's been mentioned here now a few times, but mood disturbance is very, very common after a stroke, and post-stroke depression is the most common. It affects about a third of survivors at any one time, and cumulative incidence over a person's lifetime after they've had a stroke is over half. So it's very, very common and should be on everybody's radar. One of the important pieces that I've talked about now a few times and we've heard about here already this morning is that the impact is huge, right? We see things like increased disability for individuals who have post-stroke depressions, increased mortality, increased risk for stroke recurrence. There's less functional and motor recovery, decreased participation both in therapies as well as activities of daily living, social activities, anything like that. And all of that amounts to poorer quality of life overall. So what's the problem, right? It's very clear. I'm going to drive this home one more time. It's frequent, and it has some very, very significant implications for how well that patient is going to recover after a stroke. While depression can really significantly curtail recovery and affect longer-term outcomes, stroke survivors indicate that their mental health is still not treated as a priority. But given that it is so common and has such a profound impact, mental health should be a focus of practice for everyone who works with stroke survivors. So unfortunately, there are very few guidelines that exist regarding the assessment, treatment, and prevention of mental health in stroke survivors, making it vastly under-recognized and undertreated. Last year, I was invited to write an editorial on this topic. I included it here as well as a link if you're interested in checking that out. It was my opportunity to get on my little soapbox, so. So first, I want to address this first point of being under-recognized. So in order to address this, we must first understand what this looks like. So basically, post-stroke depression is very similar to major depressive disorder, right? So it's not really that different. You have to include things like either depressed mood and or irritability, or anhedonia, which is a disinterest or lack in pleasure in things that they used to enjoy. And then 4 of these other symptoms over the course of 2 or more weeks. There's also a diagnosis that basically has depression as part of a post-stroke feature, where you need to have either the depressed mood or the anhedonia, and then at least 2 to 4 of these other symptoms. So there are some differences in post-stroke depression as compared to kind of regular depression. So post-stroke depression patterns typically involve more sleep disturbance, vegetative symptoms, and social withdrawal than what we might see in the more typical major depression. So there are also some additional complicating issues here in terms of being able to identify post-stroke depression. Some very common presentations are things like headache, pain, GI issues, fatigue. Okay, great. This is very general, and one of the things that makes it really tricky is that these are typically the symptoms that someone would come into, say, their primary care provider for, right? They would come in for these type of symptoms rather than reporting depressed mood or anhedonia. There's also this problem with overlap of many of these symptoms with some of the things that you might see presenting as part of being post-stroke, right? Is someone experiencing, things like fatigue, some cognitive impairment, difficulties remembering, memory difficulties? Are these things that are part of depression, or are they part of them just having had a stroke? So it gets really difficult to disentangle this. And one way of looking at this is, does it matter, right? Are we treating the diagnosis, or are we treating the symptoms that are interfering with their ability to function in everyday life? And you might have different opinions on that. So post-stroke depression, very complex. And I'm just kind of touching on some of the things here, giving you an overview. Really, post-stroke depression has a different course and different consequences in terms of prognosis, depending on when it happens during the recovery process. So it's most common during the first year that somebody has a stroke. So about 1/3 of all stroke survivors will experience it after that first year, and then it kind of declines after that. It more frequently occurs in that acute phase, and when it happens in the acute phase, it's also more likely to spontaneously remit within about a year. That said, even though it spontaneously goes away in many cases, it's still really important to recognize it and to treat it. Because as I mentioned earlier, and as was mentioned in other talks prior to this one, it can seriously interfere with rehab, right? It can really interfere with their participation, with their ability to engage, and so that is going to have consequences down the line. When we have a later onset or chronic onset, typically that's kind of considered about 6 months out or more. We tend to see, the depression being more persistent, there's a much worse functional prognosis in terms of outcomes over the long term, so it's just more difficult to treat, likely because there are just more factors that are involved, and we'll get to that here in a second. So I just want to briefly talk about pathophysiology, recognizing that this is a very superficial. This topic alone could be an entire talk, but that's really not why I'm here. Post-stroke depression really, is the result of a complex interaction of both physiological, social, and psychological factors, right? There's kind of this interaction that happens, and it can impact how a patient will adjust, behave, and think in the aftermath of a stroke. So, it is very poorly understood. It's likely multifactorial, like I said. And again, it may vary depending on timing after the event. So oftentimes we can attribute more of the the depression to being more biological the closer it happens after the stroke. So thinking about structural damage after a stroke, thinking about inflammation, and we'll get to that in just a minute, thinking about neurochemical changes, anything like that, likely to have a higher, be a bigger contributor in terms of the depression. And then you have the psychosocial piece, which are things like somebody's role changing, perceptions of their support, whether they have a history of anxiety or depression before they had the stroke, and their experience of functional decline. So it is a very complex picture, and understanding the pathophysiology is important because it may actually help us manage it better, right? So if we have a more biological cause, then medication might be a better treatment or might be more effective. If it's more psychosocial, we might look to behavioral type therapies or talk therapies. So some risk factors for post-stroke depression. I want to kind of preface this by saying that there are very few prospective studies that have examined risk factors to developing post-stroke depression, and only a few of these actually ended up proposing a specific model, and replication of any of these findings has been limited. So keep that in mind. But the best we can do at this point is that we know that there are certain genetic susceptibilities, right? Somebody might just be more vulnerable based on some genetic mutations or genetic variations, I should say. Also, depending on where the person had the stroke, so the location in the brain, we know, there's some good evidence that left frontal or left basal ganglia lesions within about the first 2 months after a stroke are at higher risk for post-stroke depression. There is some literature out there that kind of talks a little bit more about left hemispheric stroke tends to be more related to depression. But there's more and more research that's been coming out that shows that it's actually fairly inconsistent, so it's not reliable. And really, this is probably the best supported just in terms of the evidence. And then there's also this issue of inflammation, which, after a stroke, there is going to be inflammation in the brain. This involves increased levels of pro-inflammatory cytokines. So, that in and of itself, we know inflammation is related to depression as well as some other mental health conditions. But this isn't just for that acute stage, right? It's also for more prolonged stress. You can have increased inflammation. You can have a dysregulation of the HPA axis, so anything that involves kind of that stress response. And kind of the short version of this is that can actually impair neurogenesis and neuroplasticity, which we talked about earlier is absolutely critical for our patients in their recovery and rehabilitation. So again, we really want to make sure we are able to identify and then also address post-stroke depression. So in terms of some other factors that are associated, I keep wanting to wander off too. I'm a wanderer, and I kind of catch myself. So in terms of some other factors associated with post-stroke depression are, things like stroke severity, right? We know that in terms of stroke severity, that is fairly consistently associated with greater risk of post-stroke depression. Having functional and cognitive impairment also. So physical disability, ADL impairment, cognitive impairment, especially executive dysfunction, those are all associated with being at higher risk. Having depression and or anxiety before the stroke, so kind of having had a history of it, is also associated with that. And there's some mixed findings about age, sex, education, and type of stroke, as I'd mentioned. Typically, women tend to be at a higher risk of depression in the general population, and we tend to see similar things in post-stroke depression, although there's not as much of a difference. And then aphasia, I have it starred here because, as was talked about earlier, it is absolutely associated with greater risk of post-stroke depression. That said, the research on it is it's just not there, right? This is another one of my little soapboxes, but patients with aphasia, they tend to get excluded from all of these larger studies. And, I hope that changes with some of the exciting things we heard about earlier in terms of measuring and assessing outcomes. There are more clear patterns when looking at some other risk factors. Most of them are psychosocial in nature. So things like low social support, isolation, low community participation, those are all shown to be linked to increased risk of post-stroke depression. As a final note on post-stroke depression risk, it's important to note that the relationship between functional status and depression, so here in this picture, is bidirectional. So having higher functional disability is a risk factor for post-stroke depression, but depression can also lead to further disability and a decrease in functional status due to things like poor medication adherence, poor maintenance of healthy lifestyle factors, not engaging in therapies, use of nicotine or alcohol to cope. And so again, I just wanted to show this because it's really important for us to identify and treat post-stroke depression to disrupt this cycle. It's also, when we're talking about stroke patients, it's also really important to think about the bigger picture and to screen for health conditions like thyroid disorders that can cause depressive symptoms, for example. There's also some other chronic conditions that are associated with chronic systemic inflammation that can also appear similar, right, to depression, and the medication that we use to treat inflammation, like corticosteroids, for example, right? They can also have side effects like mood swings. So really important for us to think about the bigger picture because it is complex, as is our patients. The other thing that I kind of wanted to talk about is cognition. This is really, really important in terms of case conceptualization and planning treatment. So it kind of has a sort of a double effect, if you will. Sometimes it's really difficult to figure out whether a client is disengaged because they have difficulties with memory or attention cognitively, or whether they're depressed, right? So that's an important thing that we want to try and tease out. Depression can also significantly impact cognition. So we know that people who have depression, they also have they're more likely to have cognitive impairment. So then you might compound an issue that's existing in someone who's had a stroke. Oh, okay. Remember Daniel? Let's see if this works. This is my first time trying this, so we'll see if it... Ooh, all right. So based on, okay, there should have been a QR code for you to scan here. Right there, in that bottom left corner. So we're gonna do this the old-fashioned way. How many of you think Daniel is depressed? Wow, all right. How many are not sure? Okay. That's an overwhelming majority, I would say. So I just kind of, recapped here all of the things that he had mentioned. But remember when he was asked if he was depressed, what was his response? Say that again? Like everybody else. I probably don't feel much different than most people who have had a stroke. And this is a surprisingly common response in stroke patients as well as families, right? Well, of course I'm depressed. I had a stroke, right? Of course I feel like this. Or of course my partner feels like this. They had a stroke. So it is then up to us to figure out what's going on and to provide some psychoeducation, maybe. So with that, I'm going to move into some practical application. So screening. The first step to treating post-stroke depression is to recognize it. So we already mentioned some of the barriers, right? So stroke symptoms often overlap with symptoms of mental health conditions. There are other conditions that can be mistaken for post-stroke depression, or otherwise hinder identification of post-stroke depression, for example, aphasia. And mental health conditions can be really difficult to identify during a typical visit. Say we're in an outpatient setting where maybe it's a primary care setting. It's, typically, it might not be something that's part of the presenting issue, I guess, or the referring question. Mental health concerns are typically not brought up by patients or caregivers. And they may not develop until later when there's not routine screening that's happening. So one of the things that I would strongly encourage, and that's also part of the practice standards that were presented in the presentation prior to this. There was that nice, I can't remember how many pages, 76 pages, or what was it? But it's also mentioned in there. So having a standardized psychometrically valid screening tool can be absolutely key to identifying when somebody has had has had some depressive symptoms. The key to this, though, is that you want to screen repeatedly. Again, as I've been mentioning, mental health conditions may develop at any time, right? It doesn't necessarily just happen in the first 3 months, first 6 months, first year. It can happen further out than that. And again, the concerns are often not reported to providers. You might not pick anything up, right? But part of this practice is that it normalizes kind of just having mental health be part of a regular checkup or a regular check-in, and it can serve as preventative intervention. So very few minuses here. I did include, so there's a handout that I put together that includes a list of measures that are validated, psychometrically sound. To my absolute horror, I realized that our aphasic depression rating scales and the stroke aphasic depression questionnaire were left off of that. So they're right here. They're not in your handout, but I'm happy to provide this to anyone who's interested. All of these are free to use, so that's the good news. And really, if nothing else, like if you don't want to administer something that has, 4 to 9 items, the PHQ-2 is a wonderful screener. I did include a copy of it in your in that packet as well, if you're not familiar with it. Oh, I will add that There was a study that had shown that for like an outpatient clinic, if they were not using a screening tool, the providers were able to identify about 40-ish% of those individuals who had depression. That jumped to 88% when they did include a screener in their practice. All right, it's that time. Poll time. Do you use a depression screening tool in your practice? If you are, raise your hand. Okay, excellent. So we could do a little bit more to have that be part of our regular practice in various settings, as appropriate. So it's great, right? Screening does work, but not if that's all we're doing. So this was a bit of a staggering study. There were actually a couple of large-scale studies that were done on looking at whether patients actually ended up receiving any treatment for post-stroke depression. And that's actually what that article in that editorial that I wrote was actually specifically about this, because I just could not believe it, and I said, we can do better, right? We have to be better. So in the U.S., this was a study that was conducted, a really large national study over about 15 years, found that for all of those individuals who had a stroke, who screened positive for depression, 2/3 of them did not receive any treatment within that year for that depression. Okay, I'm going to let this sink in for a minute. Of those who did receive it, it was primarily antidepressants. We know that really the most effective treatment is the one that combines using medication with some kind of behavioral or talk therapy. So unfortunately, just as complicated as the identification of post-stroke depression is, so is its treatment. We do have a lot of different treatment strategies and options. That said, those strategies are really still suboptimal. They don't really work for everyone, right, at all times, but that's okay. We do have options. So, medical treatment, that is not really my arena because I'm a psychologist, I'm not a psychiatrist, but there is some good evidence that suggests that treating and potentially we can also prevent post-stroke depression with SSRIs. There's some studies that have shown that they may improve ADLs and survival rates down the road. Definitely as part of this, evaluating for other medical confounders, as I'd mentioned before, thinking about the interaction of different medications that patients are taking, and thinking about whether those are potentially contributing to depressive symptoms is also important. There's some evidence for neuromodulation, but one of the big caveats here is that there's really limited generalizability that has come from all of these big clinical trials. One of those reasons being that they often exclude individuals who have aphasia, who have cognitive impairment, right? So we're seeing a trend here. I hope everyone's becoming more aware. That said, I don't want to throw the baby out with the bathwater? That's a saying, right? Some other treatment strategies, occupational therapy. This can be especially helpful with some of those symptoms that are, around fatigue or kind of getting your clients back to doing the things that they want to do, right? But there's a lot of behavioral strategies and interventions that can be used. I am not an OT, but I am a big fan. So keep that in mind. Psychological and behavioral interventions here, all of the ones I listed here do have evidence to support that they can be effective for treating post-stroke depression. Starting anywhere from psychoeducation to cognitive behavioral therapy. Although I'm going to say here that for someone who has cognitive impairment or maybe doesn't have good insight, CBT is probably not your best choice. Behavioral activation, that's a pretty good one for using with clients or patients who maybe do have some difficulties with cognition. Mindfulness-based therapies, acceptance and commitment therapy, problem-solving therapy, and stress management among that list as well. And I did include those on your handouts. I do want to note that these were published as part of kind of a tear-out page that we had put in for archives. And so that's why it has that you language in there, because we actually did create it or intended to be used for distribution to patients and their families. I'd also be amiss if I didn't talk about some of the self-care or the no prescription needed strategies here, although arguably we can have prescriptions for physical activity, right? So physical activity is actually the intervention, if you will, that has quite a bit of evidence behind it. So, for example, there was a fairly large meta-analysis that was done that included 13 studies, about 1,000 participants, where exercise actually resulted in less depressive symptoms immediately after the program was ended, but it doesn't seem to have kind of the sustainability 6 months out, or it doesn't really retain much longer than that. That said, I think this has a lot of promise, and we really need to think about how we could implement this with our patients, because this is something that we probably want them to engage in anyway, right? Sleep, also really important. Sleep hygiene, good nutrition, social support, so kind of encouraging things like socializing with friends and family, joining support groups, positive coping, so this is kind of that, purpose, meaning making, expressing gratitude, a sense of humor goes a long way. And then I love that care partners were brought up in a couple of the talks as well already. I think I've now talked about this the last couple of years as well. I do think that many of us are aware that mental health is a big concern among our stroke survivors. Maybe less are, realize that care partners are just as high of a risk as stroke survivors. So about 1/3 to half of all care partners do experience depression. And depression in the care partners kind of has a twofold effect in that it affects their own quality of life and well-being, so things like social isolation and health declines, but then it can also interfere or have a negative impact on the person that they're caring for. So really, really important that we think about that as well. Emotional well-being is interdependent in couples specifically, or other close dyads like that, where if you have one partner who is depressed, the other is more likely to be depressed as well. And here is that summary of the self-care treatments. And again, you should have these also in your handout. So let's check back in with Daniel. We love to come back to Daniel. So let's say, we ended up giving him a PHQ-2 because that's what we were using in our setting. He had a PHQ-2 score of 4, which would put him into that at-risk or possibly being depressed range. This would have been so cool if this worked. This is a word cloud, imagine it. So, really, I wanted to hear from you all, given that we have a very interdisciplinary group here. What are some of the things that you could do with Daniel, given your particular strengths, your particular trainings, your skills, your experiences as providers, therapists? Yes? Co-treat with counseling and speech pathology, yes. Other ideas? Yes?
We don't have access to a lot of those things, but moving your body in sunlight through space is a fairly potent antidepressant. So this patient's going into a wheelchair and over to the park in the beginning, and then later on we'll be wheelchaired over to the park to walk among the beautiful garden.
I love that. Yes, absolutely.
Can you repeat it for the...
Yes, I can. I'm going to give a shortened version. Sunshine, movement, fresh air, really, really good. Let's go ahead and start that as early as possible, right? And then as time continues, maybe expanded into different modalities. Moving, if there's a wheelchair that's being used, maybe the next time, see if we can do some assisted walking. I mean, not next time, but you know what I mean. You can progress, work up to that. Any other ideas? I'm going to bring our...
Get his buddies from the car club and involve them to come over and pick him up in one of their nice cars and take him for a ride.
Yes, absolutely. Remember his friends from the car club? Maybe they could swing by and pick him up to go for a joyride.
There's got to be some kind of an adaptive equipment that he could use on some of the wrenches as well.
Absolutely. Absolutely. Adaptive equipment that he could use to work on his car. Yes.
Encourage him to join a support group and his wife to participate, maybe get into a caregiver support group.
I love that. Yes. So support groups for both Daniel and his wife, who clearly is also having a hard time.
I think trying to help him lay on something that he can help out at home so he doesn't feel worthless. Trying to give him purpose.
Yes, give him something that he can work on, maybe set some goals, something that's meaningful to him, right? To make him feel like he's not worthless. That's a big problem. Absolutely. Yeah. So some basic psychoeducation might also go a long way, right? Both for himself and his wife, that maybe isn't quite clear what this presentation is. Oftentimes, that's one of those misconceptions about post-stroke depression. Sometimes a partner or a family member might just see them as being lazy, or he's not trying hard enough. He just sits around and doesn't do anything. When often, it's the depression, it's things like amotivation. Those are all things that can interfere. This group is great. Who needs a word cloud? Okay, so I'm going to kind of bring it all together here. Comprehensive stroke care does include mental health. They can be anything from formal referrals to any of these services, and again, that would include psychological services. But as was mentioned, not everyone has a clinical psychologist or, a clinical rehabilitation psychologist, available. Resources might be thin, stretched, but there are lots of other ways that we can support the mental health of our patients and their families. And, my argument is that it should be all of our jobs to check in with patients and their families and to do what we can to support them, whether it's making referrals, whether it is some of those kind of DIY, no prescription needed approaches. Let's adapt, let's be flexible to help support our patients. And then, again, I have now said this over and over again, but I hope it's really, clear that I think it's important for us to address mental health needs across the recovery trajectory. This does not end, right after the initial stroke. It doesn't end, at the 6-month follow-up. It continues into chronic management. And the presentation of how things look, why they're happening in terms of the symptoms, they change depending on where the patient is at, right, in their recovery process. But it's important for us to keep checking in again and again over the course of that time. Okay. So before I wrap it up, I'm going to tell you a little bit about an intervention that we've created and that you've now heard about maybe a few times already. This time I thought ahead and actually provided a flyer as part of your handouts in your folders. But I've talked about this study now the last couple of years. I'm really happy to say that enrollment is going well. We're at the over halfway mark now with, I think, about 106 couples enrolled out of the 200. So we're going to be doing this likely for another year or so. And about a third of our participating couples are from rural areas, so areas where they wouldn't have access to, already access to resources like this. So that kind of got me really excited because that is one of my main goals as part of this. Our approach is dyadic, so we do involve both partners in a couple. It's couples-based. And it's based around the idea of resilience. So we take a strengths-based approach. I can just tell you really quick, again, this might be repetitive if you've been here last year or the last 2 years, but we did have a pilot study that we ran a few years ago, and we did see decreases in depression and increases in resilience in that pilot study, and that's why the NIH decided, okay, I think we can go ahead and fund a bigger trial of this. This is an 8-week program, so 8 weeks is active participation. We do have various assessments along the way, so the total amount of time they're involved is about 9 months because we have a 6-month follow-up. All participation is remote. We do provide gift cards. So this 8-week journey really has them move through these weekly modules that start at reimagining us in the context of stroke, where we talk about effects of stroke on relationships. We do goal setting, so we use SMART goals as part of this, which we heard about earlier. There's a self-care module, communication, let's talk about it, where we talk about aphasia specifically, so strategies in communication when a partner has aphasia, but also just about active listening skills, because we all need that. Finding purpose and meaning, connecting with each other, which I'll actually talk about a little bit later at the sex and intimacy talk this afternoon. Stay tuned. Connecting with others, which is all about the social network and social supports, and then looking into the future. So this is just a page from the booklet that they get. So we mail booklets out to everybody. They also are free to use a PDF version, but there's lots of resources in there with every module, and then activities that they do both individually as well as with their partner. If you are interested in learning more about this, please feel free to come and ask me during lunch or at some point in time, but we are enrolling couples where one partner is anywhere from 3 months to 3 years out from their most recent stroke, and they must have a romantic partner. That is part of the inclusion here. And at this point, we do ask that they are able to read and follow instructions in English. We are working on a Spanish language version as we speak, and I know I've expressed some interest to some of your colleagues here about creating a version specifically for aphasia. That said, in the current version, we do not exclude individuals who have mild to moderate cognitive impairment or aphasia, expressive aphasia, so keep that in mind. And also, this is not couples therapy. It's always important to mention. So that's the flyer that you see in your folder. And again, if you're interested, please refer your patients if you think they could benefit from this. Reach out to us if you're interested in learning more. Either way, so we are randomizing them. Everybody who enrolls in this intervention gets the intervention. So whether they are waitlisted or whether they get to start the intervention right away, they all get it. Okay. And then finally, the other thing that I included in your packet was just a kind of a resource list for stroke survivors and care partners. Just always good to have on hand. And then I just have some references, and a lot of references. And then that's it. I think we have maybe a few minutes for questions. Yeah. Yes.
So this is kind of a loaded question, and I know you mentioned that your background is psychology, not so much in the medical treatment side of things, but you did mention inflammation as being a primary cause for a lot of the post-stroke depression. I'm curious if you have any thoughts or experience on treating post-stroke depression with hyperbaric oxygen therapy.
So, can everybody hear me? Did everybody hear the
Can you
question?
repeat that? We'll do mics from here on out, but if you want to.
So I'm going to try to condense it, but the basic question was that, recognizing that I am a psychologist, not like a medical provider, kind of, the question was around like inflammation, thinking about that inflammatory contributor to depression and whether I have any experience or knowledge about using hyperbaric treatment modalities to treat that. Short answer is I do not. And I don't know the literature around it either, but it's an interesting question for sure.
It just seems common. I mean, one of the FDA-approved items one of the FDA-approved hyperbaric oxygen treatments is inflammation. They've approved that for a long time, so it seems like if inflammation is one of these challenges with depression, to me it seems common sense that would be a good method, but I could be wrong.
It's certainly a great idea. And I don't know if anybody here has any idea or any thoughts on that. I unfortunately do not have the information, but I will look into it. Any other questions?
We have a question.
Oh.
Okay. Well, I'm realizing that the scale for depression, but is there a tool for anxiety in addition to that? I mean, I think anxiety is an underlooked symptom. Like sometimes I think it's worse than pain or depression, so.
Absolutely. So the question was whether there are measures like this for anxiety. And because this was a talk on post-stroke depression, I only included depression measures. But absolutely, there are measures just like this for anxiety. I don't know if it's possible for me I actually have a list of those that I would be happy to share. I don't know if it's possible to share them through. Okay, so I'm happy to send that out, screening tools for anxiety. I think the really interesting thing is that post-stroke anxiety is maybe not quite as common as post-stroke depression. It's actually more common in the care partners, like fairly significantly more common. But I think a lot of that is maybe because anxiety is just less recognized and diagnosed. I don't know, but it's a great question and certainly something we should be paying attention to.
We have a question from our Zoom attendee. Do you have to live in Utah to participate in your study?
Great question. No, you do not have to live in Utah to participate in this study. This is a national study. We actually have participants from all over the states, including Montana. although we're based kind of in the Intermountain West, and that's sort of where we have the majority of our participants, because everything is remotely administered, you can be anywhere in the States and participate. And just to clarify, so by remotely administered, I mean this includes all assessments as well as the intervention. And it is sort of a self-administered program, but we're not just having our participants free float out there. We do provide weekly check-ins and supports. So I don't know, for many that might be a concern, especially if we have participants who have depression.